Hey guys, welcome to ST3 Hacks. And today's topic, we're going to be looking at distal humerus fractures. Talk a bit about the background knowledge you should already have and how to structure your station. So, when we talk about distal humerus fractures, it helps to split them conceptually into extra-articular and intra-articular injuries because that's what drives risk and management. From the classification point of view, the AO system is the one that's most referenced and is simple. You've got extra-articular, simple, intra-articular, and then complex intra-articular fractures. You don't need to quote any numbers. What you need to know is that when the joint surface is involved and when both columns are disrupted. You also hear people talk about single column fractures, particularly lateral condyle injuries, and Milch classification comes here, where the fracture line extends into the trochlea. That's more commonly discussed in pediatrics, but the concept is still useful in adults. And at the other end of the spectrum are bicolumn fractures, which are both medial and lateral columns of the humerus are involved, and these are unstable intra-articular injuries that should immediately make you think about operative management and stiffness risk. From the anatomy perspective, remember the common extensor origin comes off the lateral condyle and the common flexor origin comes off the medial condyle. The LCL and MCL also originate here, which is why even simple looking fractures can destabilize the elbow. The nerves are key, so the ulnar nerve runs through the cubital tunnel behind the medial condyle, and the radial nerve is anterior as it crosses the elbow, sitting in the ACF. Median nerve and AIN nerve functions are also important to check and document. And just to clear up a bit of common confusion, the Holstein-Lewis fracture is actually a spiral fracture of the distal humerus shaft, not the distal humerus articular surface. It gets mentioned in the region because of its proximity and the radial nerve risk, but it's not the same injury. In terms of imaging, you should ask for an AP and lateral X-ray. An AP is ideally done in about 40 degrees of flexion if the patient can tolerate it. You should also consider asking for a CT if there is a fracture dislocation, if it's severely comminuted, or there is neurovascular injury, as this guides surgical management. Key concerns here would be of open injury, neurovascular compromise, and compartment syndrome. So with any station, you should start with your triple assessment. You want to ensure this is an isolated injury by performing your ATLS A to E assessment to rule out life and limb-threatening injury with appropriate resuscitation. You then should take a detailed upper limb history as mentioned in the previous episodes, moving on to a look, feel and move examination, checking for open and impending open fractures, doing a full neurovascular exam, specifically checking the radial, ulnar and median nerves, checking the capillary refill times, radial and brachial pulses. When discussing management, you should start in an escalatory manner, so starting with non-operative management. This happens with closed reduction and above elbow cast immobilization, and is usually for non-displaced Milch 1 fractures or elderly and frail comorbid patients who can't tolerate surgery, colloquially known as the bag of bones, where you kind of aim for painless pseudoarthrosis. Moving on to operative fixation, you have closed reduction with percutaneous pinning, open reduction internal fixation for supracondylars, intercondylar and bicondylar fractures, and lastly, you've got total elbow arthroplasty, where fixation isn't really an option. Complications of elbow surgery include general surgical risks such as pain, infection, bleeding, damage to neurovascular structures, stiffness, specifically in the elbow because it only has one plane of movement, heterotrophic ossification, malunion, and non-union. But remember, you want to divide them into general surgical and then procedure-specific risks. So that's it for this episode of ST3 Hacks. Keep it structured, keep it safe, and happy revising.